Good afternoon, everyone, and welcome. Today, we are excited to be joined by Christin Deal from UPMC Children's Hospital of Pittsburgh, who will be sharing her recently published abstract on post-transplant outcomes for chronic granulomatous disease. My name is Emma Mertens, and I'm the Program Manager for Education at the Immune Deficiency Foundation. On behalf of IDF, we thank you so much for joining us today for this educational event. Throughout this series, we'll explore some of the rarer types of primary immunodeficiency, providing diagnosis-specific information and support to the PI community. In offering these programs, we aim to move forward in our vision of a healthier day every day for every person living with immune deficiency. Today's program is sponsored by Amgen. It is due to their partnership and support that we can offer programs like this for the patients and families we serve. Thank you, Amgen. And next, we'll hear from Felicia Morton, founder and executive director for the CGD Association of America. She'll share a brief update from the CGDAA. Welcome, Felicia.
Hi, thank you so much. I'm really happy to be here and just so proud of this study and our collaboration with Dr. Deal and the Primary Immune Deficiency Treatment Consortium. The CGDAA is a PAG of this organization, which stands for Patient Advocacy Liaison Group. And so we work with the PIDTC and esteemed immunologists like Dr. Deal on studies like this. And this particular one is really important to our community and me personally. As you know, I'm the founder and executive director of the CGD Association of America. And the reason why I'm a founder is because my son was diagnosed with chronic granulomatous disease in 2012 when he was 5 months old. And he did have a successful stem cell transplant when he was 4 in 2016. And so I have always, of course, as a mother, wanted to know what his long-term post-transplant outcome would be. And there's not a lot of data on that. And so with that in mind, we looked at what we could find out regarding these patients. We worked assiduously with the PIDTC to come up with the first of its kind comprehensive study that looked at all aspects of patients who have gone through transplant. And I am so proud of this work. It represents about 3 years of work on our parts collectively, 2 years of work at the CGD Association, at least, to come up with all these questions, talking to our community, asking anything and everything that could possibly be a concern for parents, caregivers, and patients. And so I am really so grateful to Dr. Deal and the PIDTC for working on this project with us. I'm grateful to the Immune Deficiency Foundation for helping us raise awareness for this very important study. And on a really exciting note, the abstract for this study was accepted at the Clinical Immunology Society meeting in May that we will be attending. And so we're really looking forward to being able to stand with Dr. Deal and talk about the importance of this survey. I think you'll find there are some exciting findings in this survey as well, this survey study. And we always want to bring to you the latest news and information at the CGD Association and with the Immune Deficiency Foundation. And you can find out more about what we're doing. I invite you to sign up for an e-newsletter to find out news like this at cgdaa.org. This is where you can find out about studies that you can participate in. And we also ask that you follow us for information like this at Instagram at CGDA of America, on Facebook at CGD Association of America. We're on X, we're everywhere. So please stay in the loop so you can be a part of this type of information. Please connect with us. You can connect with other CGD patients and learn from others who've been in your shoes, who have had transplants, who have had experiences, who've lived with CGD. And who are looking to connect with people like you. So with that said, I'm going to turn it over to the IDF and Dr. Deal, and I look forward to hearing everything she has to say as well. Thank you so much.
Thanks so much, Felicia. And I just added the link to the CGDAA website in the chat if anyone would like to check that out.
Thank you so much.
All right, before we get started, a brief disclaimer. Please remember that information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We're here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. And now I'm so pleased to introduce our speaker for today. Christin Deal is a pediatric allergy and immunology specialist at UPMC Pittsburgh Children's Hospital and an associate professor of pediatrics at the University of Pittsburgh School of Medicine. Her work focuses on diagnosing and treating children with immune deficiencies and autoimmune conditions. Dr. Deal is also actively engaged in PI research and joins us today to share her recently published abstract discussing post-transplant outcomes for CGD. Welcome, Dr. Deal.
Thank you so much, Emma. I appreciate the kind introduction. I'm going to get my slides up here to share with you guys, and then we'll jump right in. Um, so as sort of everybody's already introduced the topic, this is a research project that has been a collaboration with multiple institutions, with multiple organizations. The CGD Association of America, the Primary Immune Deficiency Treatment Consortium, the University of Pittsburgh, where I am, and then grant funding from NIH and Amgen. So we really appreciate everyone's help and collaboration with getting this work accomplished. So I'm sure many of you guys are familiar with chronic granulomatous disease, but for those of you who are not, CGD is a rare disorder. It's a primary immune deficiency disorder, an inborn error of immunity, characterized by a defect in the any of the subunits of the NADPH oxidase complex or any of its chaperones, which is impairing the respiratory burst necessary for intracellular killing of certain bacteria and fungi. The result of this is that there is recurrent life-threatening bacterial and fungal infections in these patients. CGD is unique in that it's also characterized by dysregulated inflammation and autoimmunity as well. The most common form of CGD is X-linked CGD, so it's more commonly seen in male patients. Over time, treatment options for CGD have evolved, and I think as we embarked on this project together, this was something that we heard coming from families, from patients themselves, and trying to determine what treatment options are best for them, what treatment options are best for their family members. We have conventional therapy, which is treatment with interferon gamma, as well as antimicrobial prophylaxis. Hematopoietic stem cell transplant has been recommended and studied more recently. And then gene therapy has come along, and there are clinical trials where patients can be eligible for gene therapy. So I think in designing this study and trying to be helpful for patients and their families is trying to think of, the nuances that come from selecting these therapeutic options for your families and for your loved ones, and what one treatment option might be appropriate for one patient is not the appropriate option for another patient, and kind of putting ourselves in the shoes of the people who are making these really life-changing decisions for these patients, and how do we be most helpful and as you're weighing all these different options and all these different outcomes. So the kind of most recent and most in-depth article that kind of summarizes the post-transplant outcomes was this published in Blood in 2023. It was a large PIDTC study. And again, for those of you who are not extremely familiar with the PIDTC, it is a consortium of hospitals in the United States and Canada. It consists of 44 hospitals. So it's again, across multiple states, even multiple countries at this point. Patients are consented to research studies, both for treatment outcomes and then also just for study of longitudinal outcomes. So this is a really diverse group of patients. This is a really diverse group of physicians and researchers trying to get the most information, the best data. This article had 240 patients who had received stem cell transplant for treatment of their chronic granulomatous disease. And one of the biggest findings was that the overall and event-free survival for patients who undergo transplant was significantly very positive. The overall survival was about 80 to 90%, and the event-free survival was about 70 to 75% over the course of 5 years' time. And for the purposes of this study, they determined event-free survival to be, or an event to be death, a graft failure, or the need for a repeat transplant. So, so with this data and this information, it was believed to be that hematopoietic stem cell transplant is a really good and valid treatment option for patients with CGD. They have this really nice figure here where it shows that the total number of infections for these populations, this lavender color is the non-hematopoietic stem cell transplant group, so the group that did not undergo transplant, and then the orange bar are those who underwent stem cell transplant but at their baseline prior to their transplant. One of the biggest things about this paper is that the patients who underwent transplant were often sicker than their non-transplant counterparts. So you can see just between the two graphs here, or the two bars on the graph, is that the lavender didn't have as many total infections, didn't have as many CGD infections, didn't have as many bacterial infections, fungal infections at baseline, as compared to their counterparts who were undergoing transplant. The difference is that when you look at the other three bars on the graph, the navy, the red, and the green, after transplant, the patients who underwent transplant over the course of their 3 to 5 year follow up, their their infection frequency went down significantly. The total infections, the CGD infections, their bacterial, their fungal infections all went down significantly. And this is in the setting of weaning off of their prophylaxis. So E, F, and G are some of those, conventional treatment options. So as they were, getting further out from their transplant and, their immune reconstitution was happening, these patients were being pulled off of their antibacterial prophylaxis, their antifungal prophylaxis. They were being pulled off of their interferon gamma, and they were experiencing fewer infections. So this was really, really encouraging data for patients to consider transplant as, as something that will actually, allow them to stop taking certain medications, them to experience better quality of life. And then the last two graphs on here show that, again, with similar incidents prior to transplant for the people who underwent transplant and those who did not undergo transplant, they they were largely experiencing inflammatory disease and inflammatory bowel disease. But for the patients who underwent transplant, again, over the course of that 3 to 5 year follow up, it kind of drops off, and their inflammatory disease and inflammatory bowel disease really decreases significantly as a result of transplant. So a lot of really positive things that came as a result of this study to show that transplant is effective at achieving fewer infections and fewer incidences of inflammatory disease. Um, Again, in sort of thinking through this project and what this information doesn't show, is that there's not a lot of data on fertility. There's not a lot of data on mental health. There's not a lot of data on neurocognitive outcomes. These are really concrete things that people at these different centers are able to document and study. But some of these other factors really weren't evaluated, and these are things that are really, again, weighing heavily on patients and on their family members as they're trying to make these decisions and think about what their lives are going to look like after their transplant. So some of the aims of our study were to try to gather some additional data that really hasn't been studied, in sort of a really innovative way to try to ask these questions of people and their families. So our study design, we designed an online survey using a Qualtrics survey software. The surveys were distributed to all CGD-AA members from November of 2023 to March of 2024. The survey was available in English only. Within the survey, we embedded these patient-reported outcomes, the measurement information system, or these PROMIS scoring tools. We'll go into them a little bit more later, but the reason that we included them were to try to gather objective data from patients themselves, and these have been really validated for patients who are who suffer from chronic disease, as well as individuals who are in the general population. So, as a result of embedding these into our surveys, we had one survey designed for parents to complete on behalf of their child, and another survey designed for patients themselves to complete because the survey tools were validated for certain age ranges. So we did distribute two separate surveys. Here's a screenshot of our survey. So it looks really nice. You can see it looks nice on a mobile device as well as on a laptop or a desktop computer. The survey itself took about 15 minutes. And so, as a result of our survey, we had 44 parents complete the survey on behalf of their child, and 9 patients complete the survey on behalf of themselves. We did filter out a few surveys for incomplete data, but these were the numbers that we had that had complete surveys. You can see that largely the patients who completed them or the parents who completed them were for male patients. And again, consistent with X-linked CGD being the most common form of CGD. These patients were largely identified as white and as not Hispanic, Latino, or Spanish in origin. You can see, and we'll continue to kind of split this up throughout the results, is that the age in survey for the parents taking it on behalf of their child and the age in the survey of the patients who took it themselves is quite different. So the median age at the time of the survey, the parents reporting the data, those were 12 years of age. The patients who were taking it on behalf of themselves, they were about 30 years of age. And the median age at transplant was quite different too. So for parents taking the survey, the median age at transplant was 5 years of age, and for patients taking it on behalf of themselves, the median age was 29 years of age. But the median number of years since transplant was 6 and 4 years of age, which really kind of aligned with our goals for the survey, which was trying to get patients who are about 5 years or more after their transplant. So the number of years since transplant is more similar, but you can see that there is quite a difference in the age, both at the age at the time that they were taking the survey and then the age at the time that they received their bone marrow transplant. Largely, the genetic mutations reported here were CYBB or X-linked CGD. The patients were reporting that their source for their bone marrow transplant was bone marrow, and then the match or the donor for these patients was a matched unrelated donor for the majority of the people taking our survey. We did look to see where people were getting their transplants, and consistent with what we know about who is transplanting patients with CGD in the United States, the majority of the patients, I guess not the majority, the largest population of patients reported getting their transplant at the NIH. So about 20% of people who took the survey had received a transplant at NIH. With Duke and some other, really big transplant centers being close behind. But there was no one center that, outshadowed the rest. And, a significant percentage, the NIH was the largest. And that's been consistent with the data that we have from the PIDTC, the data that's in that blood paper. So we asked, again, what conditions did patients have prior to having their transplant? So we asked if they had problems with infections, problems with growth, granulomatous disease, abscesses. The largest reported pre-transplant conditions were infections, and some of the most commonly reported infections were skin abscesses. Patients also reported problems with growth, inflammatory bowel disease or colitis, and lung and liver granulomatous disease as common conditions that patients experienced prior to their transplant. After transplant, again, one of our big kind of concerns and questions was, are there neurocognitive problems? Are there mental health problems in these patients after their transplant? We asked if patients had any mental health conditions diagnosed by a physician after having their transplant. And you can see, we're happy to report that a large portion of patients report that they did not have any mental health conditions after their transplant. About 65 to 70% of both the patient and the parent report surveys reported that there were no mental health conditions. The two conditions that were reported most often were depression and generalized anxiety. And these occurred at generally the same rate that they do in the population of the general population of people in the United States. Anxiety has been reported in about 10 to 16% of patients in the United States. Depression is interesting because it does vary based on age. So for adults and children, depression is about 10% in the general population, whereas you take a population of about 18 to 28-year-old patient or people in the United States, and the incidence is closer to 20%. So there is a difference in the incidence of depression that was reported in our survey, but it does reflect that of the age groups that we were getting reports from. We asked if they had any neurodevelopmental diagnoses. We gave a few examples for this. So we asked if they had any ADHD, any learning disabilities, any developmental delay after transplant. And again, more than 50% of patients and parents reported no sort of neurodevelopmental delays or neurodevelopmental diagnoses. The patient report was almost 90% reported no. Um, for the patient report, they did select yes, and we asked a couple of questions in follow up to try to get a little bit more information. We know from the prior slide that in the parent report that about 8 to 10% reported an incidence of ADHD. And again, that's actually less than what's reported in the general population in the United States. ADHD is about 10.5%. As far as number of people in the United States who have ADHD. Um, we asked if they had any IEPs, which, for those of you who are not familiar with an IEP, it's an individualized learning plan, which you can seek for medical diagnoses in school. So IEPs can be used for things such as food allergies. It can be used for conditions that affect people's learning. It can be used to help and advocate for children for whatever additional help they may need within their school system. We asked if patients had used an IEP prior to transplant and then if they'd used an IEP after transplant. The parent report survey reported about 18% of children used an IEP prior to transplant, and then a little over 40% used an IEP after transplant. When I went to look into the actual data itself to see why are people using these IEPs, what's happening here, there's a couple of little nuances in the data. So one is that these parent report surveys, these children were about 4 to 5 years old when they were getting their transplant. So prior to transplant, they would actually not have been eligible for an IEP. So, and then after transplant, we also asked families if they were able to give us additional information about what they were using their IEP for. The majority of families reported that they used an IEP for the 1 to 2 years after their transplant, largely due to absences or homebound schooling so that they weren't exposed to as many illnesses. So things that were not necessarily neurocognitive, diagnoses or delays, more so related to the transplant itself. And again, many of those patients were not eligible for an IEP prior just based on their age and that they had not yet entered the school system. On the reverse side, on the patient report, you can see that there's actually a decrease in IEPs used when you compare prior to after transplant. The patients had kind of the reverse phenomenon happening. So they were in their mid to late 20s when they were getting their transplant. So many of them were graduating and finishing and completing their schooling. So some of them were actually not eligible for an IEP after their transplant. So that's some of the kind of phenomena that we're looking at here. Is that I think these graphs may not actually accurately represent the actual data. And again, when you look into the reports why they were getting their IEPs, it was usually due to absences or extra time so that they could have extra time to make up their coursework when they were going to their post-transplant visits and follow-ups. We asked patients and parents if they had any post-transplant conditions. And you can see that most of the parent report data shows that there were actually none of these conditions, which is really encouraging and really nice news. For the patient report, there were some higher percentages of cytopenias, thyroid dysfunction, autoimmune disease, difficulty walking was a big one for the patient reports. Um, there's a couple of things I do want to highlight, and that is that there was no report of graft failure in the people who took our survey, and there was no report of cancer, which were both really encouraging pieces of information. One thing I do want to kind of show you guys is that thyroid dysfunction was reported in about a little over 20% of patients who took our survey, and over 10% of parents who took the survey on behalf of their children. And there's an interesting piece of information later to kind of tie that back together. Um, we talked a little about these Promise Global Health scores. So as you kind of scroll through the survey, within the survey, asking the questions, about IEP and other questions, we had families and patients complete these surveys that said there was a series of 10 questions, and there was a Likert scale of, sometimes, always, never, often, etc. 5-point Likert scale on ranking of their overall health, their overall physical health, their overall mental health. And then again, these are standardized scoring systems that have been validated in a variety of age ranges, both for people suffering from chronic diseases and those who are otherwise healthy. They have a calculation and scoring tool that then would give you information on the overall global health of the people taking your survey. Both in the parent and the patient report, 84% of people taking the survey fell within one standard error of the mean of the general population. So 84% of people who are post-transplant from chronic granulomatous disease are reporting that their overall mental health, physical health, and general health is equivalent to that of anybody else in the population, which is, again, really encouraging and really great information for these patients who are, 4 to 6 years out from their transplant. We asked families about fertility, if they had conceived and had any children. Three of our patients, or 3 patients who had answers for the survey, reported successfully having children. When I looked further into the data, it looks like one, I presume, had children prior to their transplant, just based on their age and gender at the time of transplant. Several patients have undergone sperm banking, testicular cryopreservation, means of fertility preservation. So we'll be curious to see how those outcomes reveal themselves in the upcoming years. I think that this data and this information is really encouraging, that that patients have had success having children without reporting any need for any fertility assistance. And then on sort of the other end of the spectrum, again, we talked about this at the beginning, but the median age at the survey of the parent report, those children were 12 years old. So I don't know that we've fully captured this concept with the patients who were taking the survey. Now, we did have a median age of 30 for the patient survey, but only 9 participants were answering those questions. So there's still this group of 44 where largely the age is still quite young. So I think that there's still more to be learned here, but I think the data that we see so far is encouraging that there is hope here, and I think that that's really exciting. We asked patients and families if they participated in post-transplant follow-up, and those who were taking our survey, about 85 to 90% reported that they were still seeing their specialist for post-transplant follow-up. We asked, what are they having done when they go to their long-term follow-up visits? What studies are they having done? What are they being screened for? What's being assessed when they go to these visits? And the majority of patients reported that they were having complete blood counts, so looking at, hemoglobin, platelets, white blood cell counts. They're having their chimerism assessed to make sure that there's still, that their transplant is doing well and is healthy and is staying at good percentage and good counts. Immunoglobulin levels are being checked. lymphocyte subsets, so looking at the numbers of T cells, B cells, and K cells. Um, about 60 to 70% report having their neutrophil function checked as a part of their long-term follow-up. Vaccine responses wasn't checked very frequently, and you can see there's a big discrepancy in again, our two kind of survey populations here, where just over half of patients who are the younger cohort, the parent report, were having vaccine responses checked, whereas only about 20 to 25% of patient report were having vaccines checked. Um, some About 50% report that their liver function was being checked, about 60% kidney function. Thyroid function was being checked in about 50 to 60%, lipids, and about, again, potentially appropriately so, 75% in the older cohort, the patient report cohort, only about 50% in the parent report. Diabetes was only being screened for in about 28 to 35% of patients. And if we kind of think back to the chart where we were asking participants, what kind of post-transplant outcomes have you experienced? What kind of conditions are you suffering from post-transplant? We saw that there was about 20 to 30% of patients reported they were having thyroid dysfunction, and again about 20% reported diabetes as one of their post-transplant conditions. And I think that this is really interesting information here, that thyroid function is only being screened for in about 60% of patients, and diabetes is only being screened for routinely in about 30 to 40% of patients. So I think that that's really interesting discrepancy in information, and what is being done and what is being experienced by patients who have had transplants. We asked what other studies were being done as they were going to their long-term follow-up visits. These are sort of maybe less common studies, potentially things that would be done um, if there are issues or problems. So not many patients are getting bone marrows done. The echoes, EKGs, pulmonary function studies, CT scans, X-rays, MRIs, all of these are happening more frequently in the patient reports of the older cohort of our study, whereas they were happening less often in the parent report. Um, the other thing to kind of highlight here is this neurocognitive testing. So only about 12 to 15% of patients reported that they were having neurocognitive testing as a part of their post-transplant follow-up visits. And I think that's another area for improvement that we could, as providers and as the specialty hospitals around the United States and Canada, is to think about this a little bit more. And why are we only doing this in such a small percentage of patients, when we see that a lot of them are having a need for an IEP, or they are reporting, some sort of neurocognitive delays or dysfunction. So I think that this is another area for improvement when we think about our long-term follow-up for patients who've had transplant. And then these were the ones that I think were most exciting for us in kind of thinking through this data and this information. We asked, do you feel that the quality of life is better now post-transplant than it was pre-transplant? And nearly 80% of both patients and parents reported that they do feel like the quality of life is better now post-transplant than it was pre-transplant. And I think those graphs from the PIDTC data that was published in Blood really kind of highlight that, and that you can expect that post-transplant there are going to be fewer infections. There are going to be fewer medications that are needed to prevent those infections. There's less chance of inflammatory disease. There's less chance of IBD and colitis. And all of those things, I think, kind of are instilled in this answer here, where patients are reporting that their quality of life is better. And nearly 90% of patients and families reported that they feel like the transplant had been beneficial from a medical perspective. So I think that this was really kind of hit home as to, getting to the meat of how do families feel this transplant went. Now that they're a few years out, I know it's not always easy going through the transplant. There's, the day to day is a huge grind and stress, and every day is a new surprise. But when they're several years out from transplant, the overwhelming majority feels like they have benefited from this transplant and going through this process. So, in conclusion, the majority of participants who took our study reported improved physical and/or mental health as a result of their transplant, and most enjoyed an improved quality of life after their transplant. There were no reported cases of cancer or graft failure after transplant in our population, and only a few reported cases of autoimmunity. And excitingly, some reported fertility after transplant with no need for fertility assistance. And for future directions and next steps, Felicia already mentioned this, but there will be a CIS poster presentation May 2nd in Philadelphia. For those of you that are attending and want to learn more or talk more about it, we'll be there to present our data. We're going to have a full publication to come this summer. And then the other thing I wanted to just take a minute to talk about is this concept that this research was really and truly spurred by patients and their families asking questions and wanting to know more information and information that is important for them in making these really important clinical decisions. The data that we had from the PIDTC from that really nice paper in Blood in 2023 gives us a lot of medical outcome for people who are undergoing transplant. But this data that we have here is something that hasn't been looked at and hasn't even really been studied. And it was all spurred by the ideas and the questions from patients and their families. And as a result of this, I think that there is some change that we could make within the field to try to improve the outcomes even better than we have them currently. And the poster that I have here is a separate project that I've been working on with the PIDTC and looking at long-term management of patients with chronic granulomatous disease as well as Wiskott-Aldrich syndrome and primary immune regulatory disorders. This was a separate project, again, sort of spurred by patients and families and these patient advocacy groups that work closely with the PIDTC. We were asking providers about how do they treat long-term, long-term management of patients who have had bone marrow transplant for these differing conditions. And one of the things that we found is that the practices vary widely from institution to institution, and that there is no uniform recommendation for follow-up of patients who've had a transplant. And I think that this study that we've been doing with the CGD-AA really pairs nicely with this to say we need better recommendations, we need better guidelines, we need more uniform guidelines so that patients who are being seen in California are getting the same care as patients who are being seen in Pennsylvania, and that there's good data to support why we're doing these things when we're seeing patients in follow up. And I think having this information really kind of opens our eyes to some areas of need and in some areas where we can do better. But at the same time, I think it also shows that the outcomes are already really really encouraging, that the survival is excellent, the outcomes are really good, but we can do better. And I think that this study, as well as this other PIDTC study, will kind of lay the groundwork for future interventions and future studies. So with that being said, I wanted to take a few minutes to just thank the patients and their families who dedicated their time to helping us by completing our survey, and for those families who gave us feedback and questions and information and did the beta testing for us. We really appreciate that. I wanted to thank the CGDAA and Felicia Morton for all of her help and assistance throughout this process. Anika Jane, who is at the University of Pittsburgh, is one of our residents who's helped with this project. The PIDTC, the CGD working group, and the steering committee for their leadership and their feedback and their really thoughtfulness in the design of this study. And those are my references. And then we should have time to pause and take a few minutes to do some question and answer.
Wonderful. Thank you so much, Dr. Deal. All right, just gonna pull my slides back up real quick. All right, so thank you so much, Dr. Deal. The findings of the study are certainly very encouraging and very exciting for the CGD community. Excited to chat a little bit more about those during Q&A. So we have a couple minutes here for Q&A for our audience. If you would like to ask a question, we ask that you please enter it in the Q&A box on the Zoom toolbar at the bottom of your screen. And we ask that you also honor the ground rules, which we have shared at the top of the chat. All right, first question, Dr. Deal. Can you share a little bit more about the study's findings pertaining to fertility in both males and females?
Yeah, so I'll share as that because our numbers are small, I don't want to overshare details because I don't want anyone to feel like we're breaching their confidentiality. But there were both males and females who reported fertility after transplant. And they both reported that there was no need for fertility assistance. Both of those all of the patients who reported post-transplant fertility said that they had undergone conditioning regimens. Transplants were done between approximately ages 10 and 20. So I think that, like I said, I'm very cautiously optimistic that as our cohort of patients who have completed this study continue to get older, we'll gain additional information in this realm. But I think that this is really exciting information that there have been patients who have reported the ability to conceive and have children without any need for fertility assistance.
That is definitely very exciting. And in your response, you touched on conditioning, and was that something that was across the board implemented for all the folks in this trial, or did some undergo conditioning and some did not?
So across the board, it's standard for patients to undergo conditioning. So everyone reported having conditioning as a part of their bone marrow transplant. If you look into that again, that PIDTC study in blood, there are differences between conditioning regimens that are chosen and used, and there are slight differences in the outcomes of the transplant. We did not ask families to report that level of detail regarding their busulfan doses, and I don't expect families to be able to report with the extreme detail that the PIDTC was able to report. So we simply asked conditioning yes or no, and then proceeded from there. So there may be subtleties with the actual conditioning regimen used, but I didn't feel like it was a fair question to ask for patients and families to have to recall those doses of those medications.
Sure, sure. All right, and can you also talk a little bit more about some of the long-term side effects experienced by patients in the studies? I know you touched on diabetes and some thyroid issues. What else?
Yeah. I think it's really interesting that those two were reported, and then also equally reported that they were not being screened for routinely at their transplant visits. So those were sort of a couple that were lacking. One of the other things that patients were reporting that I think that we didn't necessarily touch on too much, but there were some that reported difficulty walking. Now, that was something that was reported more from patients who had had transplant at an older age. And I'm not sure, again, if there may have been some difference in conditioning regimen. But difficulty walking could be anything from, muscular problems to neuropathy, issues like that. So that was one that was, again, reported. More than 30% of patients reported that. Cytopenias, again, was reported, again, larger in the patient report population, so at slightly more than 30%. So those were two that were pretty significant percentages wise as far as the numbers of reports. And then the others that are kind of a close second, about 20%, were those autoimmune disease, the thyroid disease, diabetes. So I think that if there was kind of a sort of a range of numbers that the cytopenias and difficulty walking are actually more common. I just think that those were being screened for more adequately in their post-transplant visits. Again, I think nearly 80% of people reported getting CBCs at their post-transplant follow-up. So those things are being really kind of closely monitored and followed. And then I know that in the transplant clinics, when they are getting followed up, they're checking for their mobility. They're looking for those neuropathies. They're looking for things like that. So I think that those are more expected outcomes, whereas the diabetes, the thyroid dysfunction, those things seem like they may not be as closely followed or as closely monitored for. So some room for improvement with those.
Thanks, Dr. Deal. All right, this next question, this individual is joining from Iceland. Thank you for joining. And they shared that interferon gamma is not used for transplant over there. Do you know why there is this difference between the EU and the USA?
Prior to transplant, is that the question? Yeah.
They didn't specify, but yes, I'm thinking prior to
Prior to
transplant.
transplant, yeah. That is a great question as far as what, practice differences. Um, I think that in the United States, I think that the expectation is that you are going to sort of control the disease prior to transplant, and that doing something or giving something is better than not giving anything at all. Um, with also kind of the caveat that this conventional treatment, or treatment with interferon gamma, um, with antimicrobial therapy, is considered to be the standard of care, and then hematopoietic stem cell transplant is the alternative. And I know I keep going back to that exact same paper, but that blood paper kind of demonstrates that historically, for chronic granulomatous disease, those patients who were being recommended for a transplant were actually the ones who were more ill, they were more sick, they were more symptomatic. So I think until more recently, transplant was not thought of as an actual long-term solution for chronic granulomatous disease. It was just an option. And I think the more studies, the more data that comes out. There was that blood paper, and then there is another larger cohort in the EU. It's about 700 patients, but the data is a little bit older. It's 2020 or 2021 when they published, recommending that transplant be considered at a younger age for patients who have chronic granulomatous disease. And then our PIDTC data said not necessarily at a younger age, but be considered for more patients because the transplant outcomes are so effective. So I think for how things are done or how they are treated in the United States, it's more of the approach of this is our standard treatment, and then you may also qualify for a transplant, or you may require a transplant if you get sick enough to need one. And I think that um, some of these newer studies are showing that's not the way we should be thinking about this anymore. Is that we should be thinking about it as an equal treatment option, and so maybe we should be thinking about it instead of interferon gamma. Maybe we should be thinking at it up front as the option for therapy, and not something to kind of keep patients in good shape as we kind of try to, or in the best shape we can prior to transplant. But it is interesting in how different countries and different locations kind of look at these things.
Thanks, Dr. Deal. All right, next question. This individual asks, do you think there's any correlation between lack of graft versus host and cancer positive responses and the self-selection of patients and parents completing the survey? Is it possible that those who are post-transplant with graft versus host or cancer have simply decided not to participate?
Yeah, I think that self-selection for the survey is a big consideration for the survey, right? These are families who are motivated to participate in this research. They're motivated to share their stories, and so I think that the absence of cancer, the absence of some of these conditions, does not line up as perfectly with some of our other PIDTC data. And again, I know, like, just referencing back to that one paper, but it's the best it's the best information we have for patients in the United States. So there were some conditions that were reported in that paper that were underreported in our population. So I think that it's definitely a consideration for things like death, or things that like graft failure. We know from the PIDTC data that when I showed the graph at the beginning, is that, event-free survival, it was only about 70 to 75%. So we know that some of those patients were experiencing graft failure, were requiring, second transplants. We didn't explicitly ask if patients had required second transplants in this survey. So there may have been some who did receive a second transplant. We didn't ask them to specify. But I do wonder if self-selection for the survey had some impact in some of the scoring that we had. It's certainly a limitation of the study. I don't know um, how to get surveys from people who weren't as motivated, and I wish that I had a solution for that. But I do feel like that's an inherent limitation of our study.
Sure. All right. And from this last attendee, we're going to close out on this question. This individual shares, this is a great study and the findings are promising and so encouraging for CGD families. Are there any ideas in the works for diving into any of this further? What's the next thing or the next thing to study?
Yeah. Some of the things that we've talked about were, again, from this study and then the other study where we asked providers about what are they doing for long-term follow-up, is trying to put together some rough recommendations or some resources for families, resources for providers at these different institutions to say, these are the things that are being reported. These are the things that you should be asking your physicians. I know that Felicia and I have talked about this concept before, and trying to make some of these things available through the CGD-AA, just so that people are aware of the results and aware of the things that they might need to advocate for themselves as they're going to their post-transplant visits. So I think when we've presented this data to the PIDTC, some of the thoughts are trying to get additional surveys or additional information through kind of more rigorous surveys where it's a series of surveys, and trying to get more rigorous answers from patients and more rigorous answers from providers. But I would love to see next steps would be getting this data published, getting it distributed, and then having resources for families so that they have this information that's easy to download or easy to look up quickly on their phones when they're going to their visits. And then again, from the provider perspective, allowing them to recognize that these are areas where maybe we're underperforming across the board, that we need to be doing additional screening. One of the things that we found from our provider surveys that we really don't have good transitions of care. So once patients are reaching 18 years of age, there's just this like huge drop off, and nobody's transitioning patients well. So we're definitely raising awareness already with some of these kind of gaps in care, and I think that I would love to continue to advocate for people, families, and educate providers across the United States so that we can work together to come up with better solutions and come up with some guidelines so that we can get more insurance approval easier for things that patients need, and get more and different specialists and neurocognitive evaluations as a part of post-transplant follow-up visits as well.
All right, well, that's going to wrap up our Q&A. Thank you so much, everyone, for these great questions. And thank you again, Dr. Deal, for sharing the amazing outcomes from this study. We're so excited to hear more. I'll be at CIS. I can't wait to see the poster presentation, and just really looking forward to see what comes out of this study and all the great information we've garnered. So thank you so much. And I just will close out by sharing a few IDF resources. So Dr. Deal, we'll let you go. I know you probably want to go eat some lunch and get on with your day, but thank you so much for joining us today. It was a pleasure.
Thank you guys. I appreciate it.
Take care. Thank you. All right, everyone, we're just going to wrap up here by sharing a couple of IDF resources and upcoming events, and then we'll let you get on with the rest of your day. PrimaryImmune.org is your go-to website for additional resources, upcoming events, and more. All of our materials are free to access, print, or mail directly to you. And if we didn't get to your question during the program, you can contact our board-certified patient navigator through Ask IDF. She will personally connect with you to tackle your question and direct you to appropriate resources. You can even take IDF on the road with our engaging podcast series. You can find programs like Bold Conversations, Undiagnosed, and Chronic 20s by searching for the IDF podcast wherever you listen to podcasts. We also have a YouTube channel where you can find recordings from all of our digital education events, and today's program will be available in the coming weeks. And at the end of my portion of this talk, I will be sharing all of the links. So if you need links to Ask IDF or YouTube or our primaryimmune.org website, stick around for just a couple moments and I'll share those links in the chat. Applications are now being accepted for IDF's 2025 Research Grant Program. This program supports research initiatives focused on improving patient outcomes and expediting the time to diagnosis for individuals affected by PI. To submit your project for consideration, download the application, which we have linked on screen. Are you looking for ways to connect with others who are also navigating life with a PI? You might be interested in joining one of our many Get Connected groups. These groups are free, virtual, volunteer-led opportunities to connect with others with PI all over the US. We offer location-based groups, so in your city or state, but we also have nationwide groups, and because the groups meet virtually over Zoom, you can join any group, time, leader, or day that works best for you and your schedule. We even have groups for seniors, young professionals, and folks who work in healthcare. We also offer facilitated support groups for young adults, parents, spouses, and partners. Here at IDF, we're proud to offer educational programming each month and various in-person events throughout the year. Here's a look at what we have coming up in the next couple of months. Oops, go back to that real quick. And before we conclude, we want to thank you all for joining us this afternoon. We really appreciate your participation, and we hope to see you back for more programming in 2025. Thank you to Dr. Deal for leading this talk and to Amgen for their generous support of IDF's educational programming. A big thank you also to Felicia Morton from the CGDAA for collaborating with us on today's event. Thank you so much, Felicia. Again, I'm going to leave the Zoom up for just a couple minutes while I share some of the links that I touched on in this last portion, and feel free to check those out. Otherwise, take care, thank you for joining us, and enjoy the rest of your day.